that I'm. Okay, so just taking a step back before we dive into the specific paper, what is the policy discussion and the literature in this market is about? So broadly speaking, this is sort of about the classic make or buy question in social insurance. So if we have a social insurance program, in this case, a contributory social insurance program, should the government run this program or should it procure insurance from private firms? It's an enormously important policy question, as just in the US health insurance context, about $1 trillion in annual public spending is spent on this kind of procurement payments to private firms through various privately provided, publicly funded US health insurance markets like Medicare Advantage, the largest example, Medicare Part D, Affordable Care Act, and so forth. But this is also the question that shows up in the discussions of the design of unemployment insurance, disability insurance, social security benefits, both in the US and many other countries. And there's been a pretty large literature trying to understand how to design these enormously big programs that redistribute a lot of money that is both contributory in the sense that people are paying earmarked payroll contributions specific to these programs and are also partially funded from general tax revenue. I would say there are three questions that generally arise in this literature about the design of this sort of private provision of public benefits. One is the payment design. So if we buy social insurance, how much should we pay private entities that are going to provide it? And that is where this paper is going to live. So it's going to be about the design of payments to these private firms. The second question that arises is productive efficiency. Does competition produce better insurance? Matt is sort of essentially going to assume that it does, but I would say actually the evidence on this is pretty limited. We don't really know whether it's hard to define what does it mean to be a more productive insurer, but the evidence on the productivity advantages is not as good as we would like to have. And then third, there is an enormous literature on consumer choice architecture in these different programs. If you have private firms providing insurance, how do you design the choice architecture so that consumers can effectively choose? So Medicare Advantage program that Matt is going to study here, it today accounts for about 50% of Medicare enrollees. So it's a kind of a 30 million people program these days, and it's about 50% of Medicare spending, so in the order of $500 billion. And it has been the poster child for studying for the research of market design in this privately provided, publicly funded social insurance program. So on its own, this program is incredibly important. So zooming in on Medicare Advantage specifically, what do we know? We know that Medicare Advantage plans spend less on comparable enrollees through different utilization encouragement. We know that MA plans also tend to cream skim healthier enrollees, although that exact point is sort of up to debate, and with each subsequent paper, we go back and forth on this a little bit. And we also know from some more recent work that MA plans are not created equal, and some of them prolong life while some tend to increase mortality. We also know that MA program generates substantial consumer surplus, but a substantial surplus, but a substantial fraction of that surplus is captured by imperfectly competitive insurers, and the changes in transfer design, so how exactly the government pays these firms, could alter the level and distribution of such surplus. So Matt's paper here is going to continue this line of thought and study how the design of payments to firms may affect allocation and welfare, and I will tell you a bit more about how he innovates in his paper relative to this existing literature. So I think the innovation from my perspective of reading this for the first time, obviously, is that he's going to write down a model of a MA market that is going to tie together a lot of other things that people have done in other papers. So it's not going to be the first paper to write down a demand and supply model of MA, but it's kind of going to be one of the most comprehensive papers. So he's going to allow for many, many different features of the market. Obviously, that comes at some trade-offs. You're going to allow for many things, so he'll have to simplify certain parts of the market, but there is presumably a big value in trying to evaluate all parts of the program in one coherent model. So that's great. One of the more specific innovations in the paper is going to allow for endogenous entry of Medicare Advantage plans, which has traditionally been kind of one of the hardest parts to get traction on in these kinds of papers. Other aspects that I really liked of the paper is that he's going to show us reduced form evidence of what is driving the variation in the data, which doesn't always happen in a structural paper like this, so this was very nice. He's also going to show, which I find super interesting, but I unfortunately won't really have time to go into in this short presentation, is that he's going to show the sensitivity of the model output to key modeling assumptions. So he'll basically say, well, so I'm going to introduce this endogenous entry. Suppose I were not doing that as people do in other papers. How does that affect my results? Okay, so let me give you a bit more detail, and really relative to the real paper, this is going to be a lot, like very little, on what exactly is happening here. So we're going to go through the model of the MA market. That's essentially 90% of the paper is developing and estimating the model, and then we'll do some policy relevant counterfactuals with it. So the model of the MA market is going to have consumers, firms, and the government, and then we're going to do counterfactual simulations of alternative payment policies. Okay, before I give you some Greek letters on how Matt sets up the model, let me just make sure that we all remember how Medicare Advantage payment works today. So CMS is going to make risk adjustment and relief month payments to private MA firms that are going to provide this insurance to people who decide to opt out of traditional Medicare. How are these payments going to be determined? So CMS will compute and announce county-specific costs, which they'll call this benchmark, of traditional Medicare benefits to a typical beneficiary. So basically, in some simplified way, think about like CMS sits down, computes what does it cost me to provide traditional Medicare to someone in county A, and I'm going to say like that's the benchmark to which I want to ask private firms to tell me how much do you think it would cost you to provide the benefit to the same beneficiary. So then all MA firms are going to submit what CMS calls bids for each plan, which is essentially in a normal market would have just been their prices. So they're going to just say, we think that we need so much revenue to cover this beneficiary. And then firms are going to be paid at most the benchmark. So if they bid below the benchmark, they'll get some portion of the difference back. If they bid above the benchmark, they'll have to pass through the additional premium to the consumer. And then there will be some risk adjustment packaged on top of that. So broadly speaking, the key thing that is going to drive the reimbursement decision, the payment decisions of CMS to Medicare Advantage plans here is the setting of this benchmark. So what is that amount? They set it as a cost of traditional Medicare, but in some sense they don't have to. They can set it to be anything they want. And then secondary, how does this benchmark translate exactly into consumer premiums, and how are the premiums split essentially between what CMS pays and what consumer pay? So all of these are design decisions that could be in principle altered in alternative policies. Consumers here are going to pay taxes into the Medicare fund or Part A premiums if they did not pay sufficient amount of payroll taxes. So this is something kind of the overall payment flow, I guess, or public financing of Medicare in general, Medicare Advantage, is not something that Matt talks a lot in the paper, but I think given your counterfactuals, that would be potentially useful, just institutional context. Then consumers are also going to pay Part B premiums, regardless of whether they enroll in traditional Medicare or Medicare Advantage. And then if they choose Medicare Advantage plans, there will be an add-on premium for some plans, but many plans will also have a zero. So the important thing to keep in mind here is that if I opt out of traditional Medicare and go to Medicare Advantage, it is not that I can sort of currently, I don't take my Part B premium with me in some sense and pay it to the firms. Instead, I will just pay Part B premium to CMS, and then we'll get sort of a free Medicare Advantage plan, free in the sense of like there is no extra payment on many plans. Okay, so that's the setting. So we're going to try to model. Matt is going to try to model the setting. I'm just trying. I will try to just describe what he did. In the following model. So the idea is we want to understand, I guess going back to how this benchmark thing works, we want to understand how firms and consumers and the government operate in this market, and then ask what happens if we change this payment mechanism. That's going to be the point of the exercise. Okay, so the model here is going to proceed in 2 stages. Matt had a useful figure that I'm going to borrow here. So in stage 1, because he's going to allow for endogenous entry, that is what generates 2 stages in the model. So in stage 1, firms will observe their fixed cost shocks and some information about shock distributions for the second stage. But basically, in stage 1, firms observe something about fixed costs, and they decide whether to enter and which characteristics of plans to offer. Then, conditional on this entry and realization of characteristics, in the second stage, in the second stage, we move to a more standard MA model found in many other papers that are not necessarily many other papers of MA, but in kind of this general literature. Firms are going to pick premiums. Consumers will make a choice between whether to go to traditional Medicare or opt out into Medicare Advantage, and then if so, which plan to choose. Then consumers, conditional on their choice of plan, will pick, and their realization of health shocks, will pick utilization amount of how much healthcare they want to consume, and then firms will have realized profits as a result of this procedure. So Matt is going to carefully model each step here, which, as you can imagine, ends up being a very involved model. So let me see how much detail I can give you in about 15 minutes. Okay, so we start with demand for plans. We'll have consumer I, who is going to be characterized by some vector of observable characteristics C. So these are going to be essentially demographics, especially the low income status, which will be an interesting variable that he observes in the data, as well as pre-existing conditions. So we have people who vary on these observables. Then people will also be characterized by risk aversion that can vary in the population, and their elasticity to the price of healthcare or the degree of moral hazard. Okay, so this will be a very rich characterization of each individual. Then each consumer in county M in year T will choose whether to enroll in a traditional Medicare plan or a Medicare Advantage plan. Each Medicare Advantage plan will be characterized by some feature vector X, as well as price P, where here the price is this sort of add-on premium. And people will be choosing a plan from their menu so as to maximize their utility, conditional on their expectations about their health shock and their healthcare consumption, as well as their prior choice between traditional Medicare and Medicare Advantage, to capture the idea that traditional Medicare is sort of the default that can attract a substantial fraction of people. Now, the sort of health shock expectations will be constructed within this C vector of observables, so people with the same observables will have the same expectations about their health shock and healthcare consumption. Okay, so then, conditional on that sort of setup, people are going to maximize a CARA utility, where there will be a psi parameter of risk aversion, as well as this expected return I from buying an insurance plan, and that will be a function of plans features, plans prices, as well as people's beliefs about the utility they'll get when their health shock is realized and they do go and consume healthcare. Okay, and will allow for some heterogeneity in these parameters, especially interesting heterogeneity by income. So this part of healthcare utilization will be sort of, in reality, Matt solves the model backwards. So conditional on your choice of plan, what healthcare utilization are you going to choose? So again, consumer with the same characteristics, conditional on their plan choice, which will govern the network that people face, as well as the generosity level. So this will, the plan that people choose will sort of affect two things in the model. One is, how costly is it for you to get utilization? So this is sort of a proxy for utilization management. If you're in an HMO plan, they will, create more hoops for you to jump over to get to care. And then there is the actual monetary cost, which is out-of-pocket cost. So people will be choosing the amount of healthcare consumption conditional on their realized health shock age. And that utility will be the actual value from healthcare consumption, so the value of sort of fixing your health, which is specified in this quadratic form, minus the non-pecuniary, I would call it, cost of going through various healthcare management hoops, as well as the actual out-of-pocket cost of healthcare consumption. Okay, so then people will choose the amount of healthcare consumption. The key parameter here that Matt is interested in is going to be this thing omega, which will measure how sensitive you are to the price of care in your response to care. So this will be the moral hazard parameter. Okay, and that then, so this U feeds back into the demand for plans where people's utility from a plan will be features of the plan as well as people's prediction about what will happen once their health shock and healthcare consumption are realized. So that's people. Now firms. There will also be sort of a two-stage process in the firms. Let's start with stage 2 here. So recall from the picture of the model, stage 2 is when we have firms have already made their entry decisions and they have chosen their product characteristics. So now in stage 2, they will be choosing prices to maximize their profits. So choosing prices in this context is not straightforward because what they're going to do is they're going to choose these bids or submissions to CMS of what their expected sort of revenue or desired revenue, I should say, is. And then the subsidy rules, as they are currently set up, as I introduced to you before with the benchmark and so forth, they will split effectively how much of the bid is paid by CMS and how much of the bid is paid by the actual consumer when they purchase the plan. And then there will be always risk adjustment in the background that I'm sort of simplifying, but that of course significantly affects both incentives of the firms and the revenue of the firms, and Matt will be modeling that carefully in his paper. So then conditional on entry decisions and on the product characteristics, these firms are going to choose these bids to maximize their profits. What are their profits going to be? They're going to be marginal revenue minus marginal cost times their share of their product in the market times market size, and that all is going to be added over across different consumer types and across different plans offered by the same firm. Okay. The firm's marginal cost, importantly here, Matt is not going to try to invert marginal cost as is sometimes done in this literature. Instead, he will actually observe rich data on realized costs, and so he will be able to sort of model them costs directly, and so marginal cost will essentially be just a function of healthcare, a realized healthcare utilization of consumers that enroll in this plan, and marginal revenue will include this benchmark structure, which is where we will then be hitting the model in the counterfactuals, changing that structure, and see how it sort of fiddles through the rest of the model. In stage 1, and this is one of the main innovations of this paper relative to the existing literature, Matt will allow for firms to endogenously decide, depending on their expectations about the benchmark, about healthcare utilization, about enrollment by potential consumers, to decide whether or not to offer a plan in each market in each year. And Matt creates sort of lays out an argument for why this is a sensible sort of story to think about these firms literally every year deciding whether or not to enter specific markets. You should think about this, and I think this is a reasonable argument. These are sort of firms that are already certified in principle to offer Medicare Advantage products. They're kind of health insurance anyway, health insurers elsewhere anyways, and so they can sort of easily, the cost of entry is really establishing or reestablishing their network for that specific year, but it's not that crazy to assume that this is actually an annual decision that firms can make at every year, market by market basis. So Matt is going to assume here that fixed costs are going to be additively separable across markets. So establishing a network in County A versus County B is not going to be somehow interacting with each other. And so then the firm will enter the market if its expected variable profits that we discussed in the previous equation are greater than the fixed costs. Whew, okay, so we have people, we have firms. Now the government. The government here is easy. They're just gonna, take some taxpayer money and throw it on people. So it's like not a very. So the government will be doing multiple things here. They will be setting cost sharing in traditional Medicare that of course determines the relative attractiveness of traditional Medicare relative to Medicare Advantage. They also set benchmarks B, and they also pay firms according to subsidy rules. So they come up with the subsidy rules. I should say in the background, again, in practice, they will also be setting tax rates and traditional Medicare prices. So I would push you to think more a little bit about kind of the real public finance questions of how this market works in the background, especially since about half of Medicare funding is going to come from this payroll contributions and not general revenue. So in some sense, people have prepaid some of their premiums. So how do we think about that when you talk about shutting down subsidies? What does that mean exactly? Okay, welfare here is going to be a sum of consumer surplus and producer surplus, net of total government spending of traditional Medicare and Medicare Advantage. I think this formula is something I would love to chat with you offline afterwards, because I think consumer surplus here is going to be defined relative to the outside option, traditional Medicare, same for profits, but G in some sense should also follow that. Otherwise, you will always be getting very negative surplus because you don't have sort of surplus from traditional Medicare in the estimates. Okay, so to summarize, we're going to observe realized benchmark subsidy payments, premiums, enrollment decisions, realized utilization, and the goal will be to simulate the allocation under alternative subsidy payment rules. For that, we need to estimate the unknown parameters in the model. So Matt is going to do a GMM procedure where he picks a bunch of moments and he's going to fit his observed, the moments generated from within the model with some assumptions about parameters to the observed data and iterate until he finds the parameters that best explain the data. Okay. I'm going to skip the general description of so the data is going to be on Medicare Advantage. I'm guessing you guys have seen sort of tables like that of how many plans are entering in different places. One thing that I will flag about the data that is very cool about this paper is that Matt has access to this new CMS encounter data for Medicare Advantage, which allows him to estimate the firm's costs directly. I would love to see more descriptives. You sort of say, well, this is the first paper, to use this encounter data. And I was like, yes, exciting. I'll finally see what's in that data. But you sort of, like I realized that there is a lot going into the paper already, so it's hard to say, well, let's do more. But I would love to just see some actual summary statistics from the data, because indeed it hasn't been as utilized yet. Okay, so Matt will also go very carefully through the various identification arguments. There are obviously lots of parameters moving around here. The main argument here will be that there will be policy-driven or this benchmark-driven variation in plan generosity as CMS moves benchmarks, that moves plans incentives to offer plans of different generosity, and that kind of generates the variation in the data that we like to estimate different parts of the model, because essentially we're going to sort of assume that people in different places and different points in time are going to face as good as randomly assigned differences in how costly various generosity levels of plans are. Okay, this was a lot of work. What do we get for this? In the last 5 minutes, let me tell you. Okay, so Matt is going to run 3 counterfactuals. This will be policy analysis of alternative payment levels and mechanisms. In the first counterfactual, he'll say, suppose we did not pay Medicare Advantage firms anything. What would happen? I kind of get that counterfactual as sort of the extreme case to see what happens. I think given that this is sort of a contributory program through which people have already sort of paid, I wonder whether you want to motivate that in a more, like, this is not a realistic policy to ask people to first pay for stuff and then just not give them anything for it, right, in some ways. So somehow, like, I think this is more about the mechanics of the model, maybe more than a policy exercise. So you might want to actually substitute, like where you test the how sensitive the model is to your assumptions with lowering the benchmark by $100. I wonder whether you might want to take this like removing benchmark into this more like modeling exercise rather than a policy exercise. But we can chat a bit more about that. And so then the other 2 counterfactuals, I guess I would call them a bit more realistic. So counterfactual 2 will move the subsidy from being given to firms to being given to consumers. So this is sort of like, actually this exists in some other settings. So for example, in the German private insurance market, you can kind of take your contributions from one plan and go them to another plan. So this is sort of this kind of idea that yes, you paid your payroll taxes into the Medicare program. Now can I just take my money and go shop around with it? Which essentially is kind of how Medicare Advantage funding currently works, except that no one just gives you a check and tells you go shop around. They sort of funnel that and decide themselves how much to pay these Medicare Advantage plans, and then you kind of get the choice of, say, zero price plans around them. So this is an interesting, I think here it is important to talk more though also about kind of why does the legal incidence of subsidy on whether it's on consumers or producers matter, because in sort of an 101, Econ 101 sense, it shouldn't, right? So I think kind of talking more about that intuition would be important. And then in the third counterfactual, Matt develops what I guess is, you don't call it an optimal subsidy, but sort of like a subsidy that essentially allows you to keep a similar allocation to the one that is observed today, but reduces government spending. I should note that because the model is so rich and complex, in practice, when simulating this alternative subsidy policies, Matt is going to focus on one state, Massachusetts, where you can kind of simplify the state space of how many players you have. So there will be sort of two main insurers who already offer only HMO or PPO networks. So then these insurers in the model, in the simulation, will be choosing whether to set high cost sharing, essentially, or low cost sharing. Okay, but setting that aside, so the baseline simulation, we have, just to fix ideas, 17% Medicare Advantage market share with, on average, $3,000 in utilization. So I guess that's like MA payments. I wasn't like MA in the sense how much the insurer pays or the total spending. So maybe clarifying what exactly, what that is exactly. But the key thing is 17% is in Medicare Advantage. And then if we remove subsidies, everyone leaves. That seems to make sense because if you remove subsidies, essentially you're asking people to pay instead of $0 per month on the order of $800 per month. And realistically, traditional Medicare is not $800 per month worse. Okay, so that makes a lot of sense. But I guess that's a good one to see because if it makes sense and the model is able to generate that, that's good news about the model, right? And then if we give untargeted subsidies to consumers, so if we sort of take the same money that we're giving to firms and now instead move them to consumers, enrollment jumps by a substantial amount, and it seems like then MA is attracting relatively healthier patients. Now this one, again, I would like to understand the intuition behind it. Like I understand the mechanics, but sort of the intuition behind this a bit more. Why does it matter whether we pay firms or consumers in this setting? Because in essence, what CMS is doing, it is sort of channeling the same subsidy to firms. So I think what ends up happening is that if you move it to consumers, you somehow end up paying, relatively speaking, more. But like somehow, I think maybe just reporting what are the prices in those contexts, right? So the firms are not able to raise prices, I guess, enough to grab back the full subsidy that they otherwise would have when they are paid directly. And then finally, he develops these targeted subsidies where the idea is to lower the subsidy by $100 per month to the firms and give a fraction of that as an extra subsidy to consumers and then do some reallocation of reoptimization of risk adjustment. What this allows Matt to do is essentially say, look, like this kind of gets us to an allocation that is similar to what we have today, but amounts to spending much less on Medicare Advantage, which you can see here. Okay, so you kind of save about $500,000, I guess billion. No, wait. What units is this in? 500,000 units in the table. Okay, so the takeaway: payment structure is important for how the MA market works. Whether subsidies are given to producers or consumers appears to matter a lot here, which is really interesting, and I would like to understand that more. We could reduce spending without substantial alter in the market by the market allocation by lowering payments to insurers and reallocating some of that reduction to consumers. One slide, I promise to then finish almost on time. So we can clarify, I have a bunch of like detailed comments on the mechanics of the model. We can discuss that offline. I think it would be useful to do more direct comparisons. I was actually trying to compare your tables to the tables in Carter et al. And Miller et al. And they're like, everyone is reporting different numbers, even though they're analyzing the same market. Like it would be somehow helpful to vary those numbers. I couldn't actually really figure out Are those comparable? Because sort of, I feel like you could report what they're reporting, which I think would be quite helpful. And my two main substantive comments is that I want to better understand the motivation for this specific counterfactuals and the intuition for their results, especially this idea that whether we pay consumers or producers seems to be the main driving force in the counterfactuals. And that would be a really interesting insight, but I think you kind of need to tell us a bit more about the intuition. And then the other thing that I already alluded to, I would like to understand the role of different types of financing of Medicare in the background and how you're thinking about that, right? Because again, when we make premium, when we make subsidies zero, that is effectively saying, hey, you paid all these payroll taxes. If you don't enroll in our public program, we're not gonna give you any of that back. That could be a reasonable policy that exists in some universe, but it's not clear that that's sort of the intent of any of these make or buy decisions. So then how to think about that would be helpful. Anyways, really impressive paper. I scratched the surface in my presentation and encourage you guys to chat with Matt more and wish you all the best luck in your job market with this. Thank you.
Great. Well, thank you for that very thorough discussion. Really appreciate the comments. I think the one that I want to tackle is the intuition for the difference between the supply versus the demand side subsidy. There's this cool paper from a couple of years ago that looks at the pass-through of subsidies in Medicare Advantage in a reduced form setting. And they identify the main mechanism as the market power to firms, that the market power that firms possess results in an incomplete pass-through of the value of the subsidy to consumers. And so my model captures that same sort of mechanism where if you give the firms a subsidy on the supply side, they're retaining some of that in the form of like the traditional markup that you would get in like a standard like IO pricing model that exists here, where just like their marginal revenue is going to primarily be driven by the subsidy that they're receiving on the supply side. So the distinction of subsidizing consumers directly is that you cut out the role of market power in the delivery of the value of the subsidy.
You don't, right? Because they can claw it back in prices. That's why usually the legal incidence shouldn't really matter.
That's a good point. I should think about that more.
Yeah, so we can chat offline.
Yeah.
But that's why I wasn't, but maybe I didn't quite follow the details.
No, I think that's totally fair. And some of the comments that you had about sort of developing more of the intuition for those things in the counterfactuals, that's version 2 is dropping soon, so there should be some clarity on those points there. But happy to just sort of like open the discussion. There's a ton there in the paper. You can get the latest version on my website, matthewbzahn.com. Yeah.
On the market.
Yes.
Questions? That's all really impressive, and I clearly there are a lot of things going on, and I didn't get all the details. But one of the things I wanted to ask you about were the firm costs and variations across. If I understood correctly, that was modeled as being the expected healthcare costs that the MA plans would pay out, which clearly would be the bulk of their costs. But it seems like they would also differ on important things like the cost of network development, price negotiation, utilization review, all that sort of thing. Can you comment on whether you bothered to model that, which could be very complex, or maybe that doesn't matter, or how much variation is there?
Yeah, no, that's a great point. The costs are driven by two components, and they were on there on the slide. There's the Q, that is the healthcare utilization costs, and then there's lowercase lambda, which are unobserved firm costs that are independent of healthcare utilization that would capture some of those things. I'm able to observe plan level margins, and so I can just recover what those unobserved costs are analytically as like the unexplained portion of costs that is not explained by the utilization costs.
Can I ask a general question about how do you make sure that your model is identified given the observed inputs that you have? And here I am struggle to understand, like, have identification and reduced form regressions. In these kind of structural models, what do you do to make sure that the model is identified?
That's a good point. There is a reduced form identification argument, and it kind of proceeds in a two-stage setup where I demonstrate how the policy variation in these benchmarks creates generosity or variation in the generosity of the insurance products that are available to consumers. And then I demonstrate how that variation in plan menu generosity that consumers are facing can actually explain healthcare utilization even when you condition on observed characteristics of individuals and their plans and the markets that they're located in. So that's the way of trying to demonstrate that this policy variation allows me to sort of separately identify healthcare utilization that's driven by your health need or your health state from this sort of like moral hazard price elasticity that plays a really important role in the healthcare utilization part of the model.
Thank you very much. Other questions?
Just one clarifying question. I hope I find. I'm very loud.
For the online.
Oh, for the online pro, okay. So there was this inequality where there was kind of discussion about if firms decide to enter a market or not. Is there a cost of exiting a market? Like you're already in that market, like is it like I formed a network, I did something, suddenly I decide to pull out, or like it's from that market, or is it just normal for firms to just kind of go into a market, next time around I go out, like what's the institutional, I just, as a clarifying.
So I think in the real world, as Maria said, like most of these firms that are offering Medicare Advantage plans are already in the insurance space. They're probably offering, they are offering plans in other segments. So I think in reality, there's probably no significant cost of exiting like a Medicare Advantage product space if you choose to. And so within the model, that's the same sort of setup. So there's no cost of exit, but there is cost of sort of certifying that your provider network meets the CMS regulations each year. So I do capture that cost.
So I'm wondering whether benchmarks are data or not, right, in the quote real world, and how important that is to kind of the results that you get. From what I understand, those benchmarks are fee for service plus kind of something about who bids, right? That part of kind of these entries drive CMS to say, well, we need to, raise our benchmark a little bit or lower it because everybody's coming in with these big numbers. And so my understanding is that there's a lot of churn in this market because firms come in with plans that presumably have no hope of succeeding except that they corrupt the auction space, right? So this is not a traditional auction where those things are all. I don't know if you think these are important or whether there is sort of, whether you can just ignore it.
No, the role of the benchmarks and, are they generating exogenous variation to sort of identify the model is important, is something that I think about. So the benchmarks have gone through a couple of different iterations over the life of Medicare Advantage, and they were most recently changed in the Affordable Care Act, where they aligned them to lagged traditional Medicare utilization in the prior year. So it's the subsidies that firms choose don't necessarily directly impact those costs. Like you can imagine an argument where if they're set in such a way where they're sort of like substantially altering the selection between MA and TM, that's how that effect could manifest. So the way that I try to demonstrate the identification power of those benchmarks is to sort of take a leave one out approach and look at the variation in benchmarks of other geographies impacting the generosity of the average insurance plan in a given market.
Do you have a question? Yeah.
I think I have a question, but it's not a very good one. So with the, and I think this kind of gets to Maria's comment earlier about why the statutory incidence of the subsidy would be different. Does moving that subsidy from the firm side to the consumer side change the way that these MA plans are competing for consumers? So are they competing on price now as opposed to just competing on network quality, et cetera, under more of a fixed MA schedule of things?
I think I think the main story is a pricing story, and price competition still exists under the supply side subsidy component, but I think that it makes when you sort of shift it out from the supply side, you're gonna really spike what the MA plans prices are. And so if you require really high prices to cover your utilization costs, your ability to still attract enrollment is gonna be limited. And so I think that will discipline prices more potentially discipline prices more because they can't raise them quite as high as they might otherwise would if there's a supply side incidence of the subsidy. But that's something that I can explore more in what I currently have and sort of really articulate what's the mechanism going on in driving that result.
I have one more question. So did you model the MA plans to be risk neutral here?
The firms are, yes, I believe so. I think they're taking they're pricing based on what their expected, risk neutral is what their expected costs will be, yeah.
So one complications of this market, obviously we know that the healthcare cost is so heteroscedastic that the risk increases with generosity, right? And I wonder if that creates some problem with big firms versus small firms in this market because of the entry consideration and the generosity itself is often pretty offered by big firms but not small firms and stuff like that, and whether that has implications for your results.
Yeah, I definitely think that could be playing a role. I don't think that I've looked at that firm heterogeneity angle quite yet, but I agree that that's definitely like an important consideration. Important consideration to unpack and consider, especially with some of these policy environments that are sort of like tweaking how we're paying for firms to participate in this market.
Okay, I guess.
Okay.
All right.
Thank you.
We are